So hello everyone. Today we can start our meeting, and here is gonna moderate the Zoom meeting. So when you are ready, I'm here. Go ahead. Thank you.
Okay.
Thank you, Dr. Nadir. So hello everyone. Welcome to our Zoom meeting today from our Brown team. I'll be your moderator. My name is Trivedi, and we can probably wait for a minute for everyone to join, and then we'll start. Our first presentation will be for the oncology and hematologic malignancies, and presenters Dr. Rawan, Elhag, and Dr. Lena Alawad. So I will actually share my screen with the first presentation. And whenever you're ready, Dr. Rawan, you can start. We'll probably wait for a minute then.
Okay.
We'll give a chance to everyone to join. And everybody can see my screen?
Yes.
Thank you.
So should we wait for more people or should we start?
We can start. It's already started recording. So
yeah, go ahead, Dr. Rawan.
Okay, so good afternoon, everyone. Today I'll be talking about oncology and hematologic malignancies, along with my colleague, Lena Alawad. So the objectives of this presentation is to actually talk about the incidence and prevalence and talk about the pathophysiology of oncology and malignant diseases, specifically in the older population, and also talk about how to assess a geriatric patient with malignancy, and then the treatments that we could apply to these geriatric populations, and then also talk about the pros and cons of different anti-cancer treatments. So moving on to the next slide. So before we treat any patient with cancer, we have to, of course, first assess the cancer and know different factors involving the patient, and then formulate a plan to actually treat this patient. So there are different types of treatments for cancer or hematologic malignancies, such as chemotherapy, hormonal therapy, immunotherapy, biologic and targeted therapies, radiation therapy, and surgery. And of course, you also have to screen the patients before and after cancer. And not only are you treating the cancer itself, you're also treating different life issues that arise when a patient has been diagnosed with cancer. So we're gonna talk about different cancers in the geriatric population, such as breast cancer, lung cancer, colon cancer, gastric esophageal cancer, prostate cancer, bladder cancer, renal cell cancer, and also hematologic malignancies and lymphomas, and multiple myelomas, leukemias, non-Hodgkin lymphomas, Hodgkin's lymphomas, multiple myelomas, and MGUS, monoclonal gammopathy of uncertain significance. So we're just going to talk about the epidemiology, and the incidence and prevalence of cancer increases with age. And 1 in 4 deaths in the US is caused by cancer. A very interesting fact in this slide is that when a geriatric patient is at the age of 70, this is the average age of risk for cancer. However, when he hits the age of 85, the risk of cancer actually declines, and it's being replaced by cardiovascular diseases, which is pretty interesting because the general thought or the general idea is that as soon as you grow up, the risk of cancer increases, which is different here because as soon as you reach the age of 85, the risk of cardiovascular disease is actually higher. Also, another interesting fact is that specifically in breast cancer and colon cancer, when you compare these cancers, in a patient who's young and a patient who's old with no comorbidities, they have the same treatment efficacy. So for example, if you have a 30-year-old patient who has breast cancer and a 70-year-old patient with no comorbidities, also with breast cancer, the treatment efficacy is the same. Then this leads us to the next slide, which answers a very important question, which is, why is it that the risk of cancer increases with age? And there are three main reasons. The first reason being some cancers are thought to develop over a long period, perhaps decades. The other important thing is the DNA repair mechanisms decline in action. They're not working as they used to. So the cell damages and all these cell damages accumulate, and therefore they can lead to cancer. Another important point is the function of the immune system, particularly the cellular immunity, which helps get rid of cancer, seems to decline with age as well. So other important facts, that the older people are more likely than other adults to present with advanced stage cancer. And there's also a general thought that the older the patient is, the less aggressive or slower growing cancer that they get affected by, and that's not true. However, in animals, it's actually the opposite. Data in animals show that the older they get, the greater risk they have of getting a less aggressive or slower growing cancer. And the molecular biology and clinical behavior of cancer is the same across the age span. So this slide basically talks about the general epidemiology, and the conclusion is that Black Americans have it worse than anyone. So the cancer incidence is actually 10% higher than in white Americans, and the cancer incidence is 50 to 60% higher than in Hispanic and Asian Americans, and 50% higher than in Native Americans. The cancer mortality, 30% higher than in white Americans and more than 50% higher in Hispanic, Asian, and Native Americans. And Black Americans with cancer have shorter survival times than white Americans at all stages of diagnosis. So Black Americans basically have high incidence and high mortality rates. To the next slide. The relative 5-year survival rates are higher among people diagnosed at younger ages than in those diagnosed at older ages. 52% among Black Americans diagnosed before age 45, and 43% among those diagnosed after age 75. Some data suggest that when quality of care is similar, outcomes for white and Black Americans are comparable. So there are a lot of clinical trials discussing the cancer in geriatric patients above the age of 75 with lesser comorbidities. And I think they're trying to compare them with cancer in younger patients to see the different treatments. And there are also trials focusing on symptom reduction in older patients as well. And surveys indicate that when fully informed, most older patients choose life-extending treatment even at the risk of toxicity. So one of the main challenges that face oncologists or geriatricians when treating a cancer patient is the risk of toxicities and adverse events. So it's the doctor's role to formulate an individualized, specific plan for each patient according to many factors, which we can assess using different assessment tools, with the best being the comprehensive geriatric assessment. So we have to have specific individualized assessment for each patient, because each patient is different than the other. And we can use a lot of assessment tools, but there's this one perfect assessment tool, or the best assessment tool, known as comprehensive geriatric assessment, which we'll discuss in the next slide. So the guidelines for both the assessment of the older patient with cancer and treatment algorithms are in process, and the National Comprehensive Cancers Network older adult oncology guidelines are the most well developed. So this is the link to the article, which I read through quickly, but I would like to discuss some main points. So what this article discusses is the pre-treatment evaluation. for a patient with cancer to see if the patient can tolerate the treatment and if there are any abnormalities that can claim them unfit. So what is this assessment? It's basically a multidisciplinary evaluation of multiple aspects which can affect the treatment choices, the prognosis, and tolerance. And it's basically evaluating 7 important points. The first being function and mobility. So how are we going to evaluate function and mobility? We're going to evaluate it using different methods. We could use a self-report, where you just ask the patient if he's about his daily activities of living or his instrumental activities of daily living, or just ask them how many falls they've had in the last 6 months. Or you can use objective measures such as the tug test. And I'm sure Dr. Nader talked about it before, which is when you ask the patient to get up from an armchair, walk for 10 feet, turn around and go back without assistance. You can also assess their gait speed, their SPPB, which stands for Short Physical Performance Battery Test, which measures the speed, the balance, and the strength of the patient. So this is the first thing you need to assess, which is function and mobility. You should also assess the comorbidities of the patient. You should also assess social functioning and support, and evaluate the living conditions and the social status of the patient. You should also assess the cognition of the patient, which is, it has been shown that decreased impairment in cognition leads to higher risk of functional dependency, depression, and high mortality. Also, we have to assess the physiological status, and it's very understandable that patients with cancer can suffer from depression and distress, and we can also assess these things using these easy exams like the mini mental exam or the NCCN distress thermometer, which is an assessment tool that was developed specifically for cancer patients who are at risk of depression. We should also assess their nutrition using a mini nutritional assessment, and of course the polypharmacy of the treatment you want to give the patient and the treatment they're already on due to comorbidities and so on. So this is what basically the National Comprehensive Cancer Network talks about in this article. And these are the things you want to evaluate for before you start formulating a plan or a treatment plan for a specific individual. So we're going to move on to the next slide and talk about the Karnofsky Performance Status and Eastern Cooperative Oncology Group performance measures. They're usually used commonly as they correlate with treatment toxicity. These tools alone do not predict outcomes in older adults, as well as the comprehensive geriatric assessment. Like we said before, it's one of the best ways to assess a patient before giving treatment. And also the geriatric assessment can detect issues pertinent to cancer management that will go unrecognized otherwise, such as polypharmacy, which we talked about, which can increase risk of adverse events from chemotherapy and increase risk of non-adherence. So what are the factors that actually lead to worse survival outcomes? These include low albumin, ECOG performance status, more than two or more, positive geriatric depression screen, which we talked about also in psychological status, advanced stage disease, malnutrition, and advanced age. So the geriatric assessment reviews the global health of the patient, including the functional status, the comorbidities, cognition, nutrition, weight loss, polypharmacy, psychological status, social support, and geriatric syndromes. Variables within geriatric assessment predict toxicity from chemotherapy, and geriatric assessment requires an interprofessional approach which aids in development of a patient-centered treatment plan, which is pretty understandable because the assessment itself is multidisciplinary. So the current forms of cancer treatment include different forms such as surgery, radiation, chemotherapy, hormone manipulation, and biologic therapy. So age alone does not preclude any of these approaches. So basically, the reason why we have to formulate a specific individualized plan for a patient, for a geriatric patient, is not because of the age itself, but because of the changes that happen with age, the normal changes, and also the diseases that we acquire as we age that are comorbidities. So moving on to the next slide. Here we're also going to talk about cancer screening and The things we need to screen for, such as breast, colon, lung, and cervical cancer, prostate cancer. However, if a patient has a life expectancy of less than 10 years, there's no need for you to screen the patient for prostate cancer. And it's important to consider life expectancy and the risks of testing, overdiagnosis, and overtreatment when recommending cancer screening for older adults. Assessing remaining life expectancy should involve a comprehensive evaluation of health status and include functional impairment, disability, comorbidity, and geriatric syndromes, which were all, I think, were mentioned in the geriatric assessment. So now we're going to talk about specific treatments and the issues or toxicities that arise with these treatments. And the first one is chemotherapy. And we're going to talk about the pharmacokinetics. So as we age, we all know that we tend to lose renal function and we have lesser GFR. So this can actually affect the treatment of geriatric patients, especially those undergoing chemotherapy, and it can lead to toxicities. And certain drugs such as cisplatin, lenalidomide, and cepicetabine are contraindicated or need dose adjustment with renal insufficiency. And there are also pharmacodynamic changes such as anti-tumor agents or multi-drug resistance that happen along with patients undergoing chemotherapy. An interesting fact is also increased hemohypoxia with age has been observed in a murine model. Other toxicities with chemotherapy include mucositis, cardiotoxicity, peripheral and central neurotoxicity, which are common and more severe with aging. Basically, most of the toxicities are more severe with age. So every toxicity you read will have more adverse effects in older patients. So cardiotoxicity is a complication of anthracyclines and anthraquinone, cytomycin C, and high-dose cyclophosphamide. Also peripheral neuropathy with vincristine, and cerebral toxicity with cytosine arabinoside. And the older population is especially susceptible to functional decline, confusion, syncope, and falls. Toxicity may have serious functional consequences in older patients. And if you have a patient that is undergoing treatment just for symptoms, not curative, the best strategy is to start low and go slow. So you don't want this patient to suffer any adverse effects. You're just trying to treat their symptoms. So the best strategy is to start slow and keep going slow. We're moving on to the next slide. And of course, myelotoxicity, one of the known side effects of chemotherapy, which is also worse with older patients, and especially with regimens such as CMF, which stands for cyclophosphamide, methotrexate, and fluorouracil, cisplatin and fluorouracil, and etoposide. And they are tolerated better for patients 70 years old and older, without life-threatening neutropenia or thrombocytopenia. However, infections are markedly increased among older acute leukemia patients undergoing intensive induction treatments. So people who are undergoing induction treatments get high doses of chemotherapy, but luckily we can use GCSF or GNCSF, granulocyte colony stimulating factors, or granulocyte monocyte colony stimulating factors, which have the same efficacy in younger or older patients. In this way, you can prevent these geriatric patients from having infections due to neutropenia from the side effect of chemotherapy. So certain neurodrugs or neuroformulations may be particularly suitable for older patients, such as oral etoposide, gemcitabine, vinorelbine, nab-paclitaxel, and subcutaneous bortezomib and liposomal doxorubicin. And then we'll move on to a different set of treatments, hormonal therapy, which we use in breast, prostate, and endometrium cancers. And they're well tolerated in older adults. But we should also consider the risk factors and the adverse events in these hormonal therapies. So moving on to the next slide. So we can use two different types of treatments for breast cancer, such as tamoxifen or aromatase, tamoxifen being an estrogen antagonist, and aromatase being an aromatase inhibitor, which inhibits the enzyme aromatase. They both can cause bone side effects and bone fractures. However, aromatase has worse side effects than tamoxifen, and tamoxifen also has cardiovascular risk factors. Moving on to the next slide. So prostate cancer, hormonal therapies, the first line treatment for systemic prostate cancer, which significantly decreases testosterone levels to treat the cancer. So because we will be giving the treatment for prostate cancer for a long time, you're bound to have a lot of adverse events. So you can have metabolic syndrome, cardiovascular diseases, osteoporosis, fractures, and physical performance decrements. And of course, prior to starting treatment, you should include an assessment of life expectancy, prostate cancer severity, and overall health status. Okay, so now we're going to move on to biologic and targeted therapies. So modulation of immune response is an attractive option in treating older patients whose natural defenses may be impaired by immune senescence. So we have recombinant alpha interferon, which is used in melanoma, renal cell carcinoma, and hematologic malignancies, and interleukin-2, which is used with curative intent for advanced melanoma and renal cell carcinoma, but typically in younger patients. These agents have been supplanted by newer immunotherapy agents. So targeted therapies influence the activity of a specific receptor involved in cancer signaling. So another important thing to remember is that most people think that these biological and targeted therapies come without toxicities, and that's not true. As we'll see, specific immunological agents and their adverse events, such as ipilimumab and pembrolizumab and nivolumab associated with autoimmune mediated colitis and endocrinopathies, and rituximab and trastuzumab monoclonal antibodies generally have mild toxicities, hypotension, and shortness of breath with first infusion, which abate when infusion rate is slowed. And then we also have adotrastuzumab imtanicine, which is an antibody drug conjugate, which causes systemic adverse effects but are more manageable. So we have targeted therapies that influence the activity of a specific receptor involved in cancer signaling. So we have bevacizumab, which is a monoclonal antibody associated with vascular adverse events given their mechanism of action, such as hypertension and thromboembolism. So bevacizumab works on vascular endothelial growth factor. And when this happens, it actually blocks blocks this agent, which is VEGF, which leads to less blood vessels growing to the tumors, which eventually leads to their death. But VEGF also works as a vasodilator. So when you block it, you also increase the risk of hypertension and thromboembolism. And also tyrosine kinase inhibitors affecting EGFR and VEGFR pathways associated with vascular adverse events. So basically anything you have that is targeting the vascular endothelial growth factor or EGFR can lead to hypertension, as you'll see in the next slide, where we'll look at certain adverse effects and then look at the class of anti-cancer treatments that actually cause them. So the first one is hypertension, and the agents that cause hypertension are VEGF tyrosine kinase inhibitors such as sorafenib, sunitinib, pazoganib, and axitinib, cabozantinib, and levatinib, and vandetanib, and regorafenib. And we have VEGFR monoclonal antibodies such as bevacizumab and aflibercept and ramucirumab. Another adverse side effect would be QTc prolongation with a higher risk in vandetanib and levantinib and BCR-ABL KIT or tyrosine kinase inhibitors, nilotinib and trioxide with a lower risk in osimertinib and BCR-ABL KIT and tyrosine kinase inhibitors such as imatinib and dasatinib and ponatinib and bosutinib, and BRAF inhibitors, which are MAPK signal pathway inhibitors in combination with MEK inhibitors, and MEK is a mitogen activated extracellular signaling regulated kinase, such as vemurafenib and cobimetinib and dabrafenib and tremetinib and ibrutinib. Another adverse effect is acneiform rash, and these happen with EGFR tyrosine kinase inhibitors, which happen more in afatinib more than erlotinib, and gefitinib more than osimertinib, and EGFR monoclonal antibodies such as cetuximab and panitumumab. We also have maculopapular rash, such as VEGFR tyrosine kinase inhibitors, BCR-ABL KIT tyrosine kinase inhibitors, and BRAF inhibitors, and anti-PD-L1 antibodies such as nivolumab and pembrolizumab and avelumab and atezolizumab, and anti-CTLA-4 antibodies such as ipilimumab and ibrutinib and idelalisib. We also have hand-foot syndrome, which is also known as palmar-plantar erythrodiertia, which can cause swelling and redness and blistering of the palms and soles. Also with capecitabine, more than 5-fluorouracil, and VEGF tyrosine kinase inhibitors, and liposomal doxorubicin. And we also have another side effect, is keratoacanthomas, other cutaneous squamous cell carcinomas, such as BRAF inhibitors. So BRAF inhibitors basically can cause a side effect of cancer. It treats cancer and causes side effects of cancer. Another side effect would be cardiotoxicity or decreased left ventricular ejection fraction, with higher risk with anti-HER2 therapy, such as trastuzumab, pertuzumab, lapatinib, and adotrastuzumab. And we have osimertinib and BRAF inhibitors in combination with MEK inhibitors. And the ones with the lower risk are VEGFR tyrosine kinase inhibitors, BCR and ABL KIT or tyrosine kinase inhibitors, and anti-PD-L1 antibodies for immunotherapy. Another side effect would be peripheral neuropathy, which with platinum, with oxaliplatin and carboplatin, oxaliplatin being more pronounced for the side effects than carboplatin or cisplatin, and vinca alkaloids such as vincristine, vinorelbine, and vinblastine, and taxanes such as Pataxil, more than nab-paclitaxel, docetaxel, and cabazitaxel. Epothilones such as ixapilone, more than eribulin, and proteasome inhibitors such as bortezomib, less common with subcutaneous administration, more than carfilzomib and ixazomib. We also have brentuximab vedotin, and immunomodulatory drugs, thalidomide more than lenalidomide and pomalidomide. Also, myelosuppression is a side effect, which happens with CDK inhibitors, palbociclib and ribociclib, and thyroid dysfunction with anti-PD-L1 antibodies, anti-CTLA-4 antibodies, VEGFR tyrosine kinase inhibitors, and VEGFR monoclonal antibodies, and BCR-ABL KIT tyrosine kinase inhibitors. Also, idelalisib more than ibrutinib and venetoclax. Proteinuria, arterial thromboembolic disease, and we discussed this earlier, VEGFR tyrosine kinase inhibitors and VEGFR monoclonal antibodies. And there are also electrolyte disturbances for potassium and magnesium. And for potassium, there is venetoclax and abiraterone. And for magnesium, we have cisplatin and EGFR monoclonal antibodies, such as cetuximab and panitumumab. And another side effect would be fluid retention with abiraterone and enzalutamide and venetoclax and ibrutinib. and dyslipidemia with mTOR inhibitors, everolimus, temsirolimus, and abiraterone. And that leads me to my last slide, and I'm going to leave the rest of the presentation for Dr. Lena Alawad. Thank you, everyone. I hope you enjoyed the presentation.
Thank you so much, Dr. Rawan.
Okay, you're welcome.
Thank you so much, Dr. Rawan, for this informative presentation. I'm going to present next slide. Just, I will share my screen.
Dr. Lena, do you want me to stop sharing my screen then?
No problem. Okay, no problem. So I will follow your slides. Just wait. You want to close your screen, Dr. Mihir?
I just stopped sharing.
Oh, okay, great.
You can share your screen.
Okay. I will share it. So sorry. Don't know what the problem. Just wait. You can see my screen now.
Yes.
Yeah. Okay, that's great. Hello, everyone. I'm Lena Elhag Alawad. I'm going to present the next slide on oncology and hematology. I will continue actually the treatment for older of cancer of the older patients. I'm going to talk about radiation therapy. Radiation therapy is safe and effective in older patients. And actual radiation therapy has been used as alternative to surgery in poor surgical candidate, mainly, and also can be used in the patients 65 years old and older. The main concern, there's actually remain concern when treatment involve irradiation of the whole brain or pelvis, but no systemic investigation has categorically substantiated this concern. Age itself shouldn't preclude elective cancer surgery, according to study in both referral centers and immunity hospitals. The length of hospital stay and time of recovery become more prolonged with advancing age. There is advances can have a benefit in older patients. These advances such as endoscopy, spinal anesthesia, laparoscopic surgical technique, laser and photodynamic therapy, and neoadjuvant chemotherapy in breast and lung cancers. The trend to manage cancer without deforming surgery may obviate complex rehabilitation and be of special value to older people. Now we're going to talk about the quality of life issues, which considered one of the treatment options for older patients. Quality of life issues, we can take QOL, instruments have not been adjusted to the special needs of older people. And actually, the problem of QOL questionnaires, the length and complexity of this questionnaire can overburden some older people. QOL research might aid the choice between intervention yielding comparable survival. There is measures of QOL adjusted survival or quality adjusted time without symptoms or toxicity are important to consider for patients for adults 70 years old and older. Research is needed in the melding of geriatric assessment and quality of life instrument. Now we're going to move to epidemiology of specific cancers. We will talk about the most 3 common cancers among women and men. Actually, they are shared on the second and third most common cancer, and they are only different on the first most common cancer. In the women, the first most common cancer is the breast cancer, and in the men, the most common cancer is prostate cancer. The second most common cancer among women and men is lung and bronchus. And the third most common cancer among women and men is colorectal. Breast cancer is the worldwide. Nearly a third of the breast cancer cases are seen in patients more than 65 years old. And in more developed countries, this proportion rises to more than 40%. Advanced age diagnosis associated with more favorable tumor biology, as indicated by increased hormone sensitivity and lower grades and proliferative indices. Actually, the more advanced tumor present in the older patients, more likely the older patient present with larger and more advanced tumors. The treatment for the breast cancer, according to the size of the cancer and a lot of factors. If the cancer is localized, the patient has localized cancer, the surgical treatment will be more supported, more beneficial than primary hormonal treatment. There is also surgical treatment for the breast cancer. One of them is breast conservation treatment, which consisting of breast conserving surgery, such as lumpectomy or partial mastectomy and post-operative radiotherapy. This conservative treatment is now recommended to be the standard of care for patients of all ages with early disease. There is also total mastectomy, which take all the breast out, remain a surgical option for older patients who prefer it over breast conservation treatment, and for those who decline or are not candidates for postoperative breast radiotherapy. And also of the patient has a large primary lesions. There is controversies in managing breast cancer in older women, such as need for complementary axillary lymph node dissection after a positive sentinel node is found. Data suggests that sentinel node sampling is just as accurate as axillary dissection, but considerably less toxic. Also, the value of irradiation after lumpectomy. There is actually local recurrence rate may decrease with age, and there is inconvenience. Cost of radiation therapy may outweigh the benefit. And also controversies regarding the value of adjuvant hormonal therapy more than 2 years. Initial management of breast cancer, metastatic breast cancer. This initial management is preferred at the first line in patient in visceral crisis. This initial management is women, if the women is 65% years old and older with metastatic hormone receptor positive breast cancer, are likely to have effective palliation with hormonal therapy. Chemotherapy has also been shown to be safe and effective in this group of patients. Now we're going to move to the lung cancer. Lung cancer, the treatment according to the type of cell. So it is divided to the small cell and non-small cell lung cancer. Lung cancer is common in older women for the reason not well understood. Some may be due to high smoking rates. Most patients present with stage 4 of the disease, okay? So the therapy will be palliative. Most likely the goal of therapy is palliative. If the lesions is not, the location of the lesion affect cannot, it's away, so we cannot do the surgery. So the stereotactic radiation will be cause long-term survival for this patient. Over the past decade, chemotherapy has been shown to produce clinical responses and provide effective palliation for a portion of patients with metastatic disease. Okay. Patient with advanced PD-L1 high tumors, the first line immunotherapy will be the option for them, which improve outcome and it's less toxic than with chemotherapy. Small cell cancer is treated with chemotherapy and or radiation therapy without surgery, depending on the stage of the cancer. The brain metastasis relapse is very common in patients with lung cancer. So newer radiation techniques being developed to minimize longer-term neurocognitive effects. Okay, now we will move to the colon cancer. Colon cancer, as we mentioned earlier, it's the third leading cause of cancer in the US. Second leading cause of cancer of death. 2/3 of the cases occur in the patients 65 years old and older, and 90% of cases occur in people more than 50 years old. Actually, the right-sided colonic adenomas more likely found in the women. Colonoscopy should be performed in all cases of hematochezia, occult GI bleeding, iron deficiency anemia, or even melena after a negative upper endoscopy. Okay, now colonoscopy become the mainstay of prevention of colon cancer because that enable direct visualization of the entire colon and biopsy. There is type of polyps may bleed or produce cancer. This type of polyps could be neoplastic, such as adenomas, non-neoplastic, such as hyperplastic, and the old age also. Old age and male gender are major risk factors for polyps that may bleed or respond to cancer. There is a colonoscopy surveillance colonoscopy called 3 years interval for surveillance colonoscopy is safe and cost-effective for most patients with adenomas. So the patient with adenomas, we can do 3 years interval surveillance colonoscopy. If it's a small tubular adenoma, we need to do follow-up within after 5 years. If large villous adenomas, we can do the follow-up after 1 year. Negative screening, if you do screening, okay, and it's negative or surveillance colonoscopy negative, we can do the follow-up after 5 years. Patients with colorectal cancer should also have regular colonoscopic surveillance for adenomas 1 year after surgery. Because this patient with colorectal cancer or have adenoma, the rate of recurrence could be 25 to 30% at 3 years. There is also option of surgical excision, which could be adequate for the lesion that confined to the colon. But if regional nodes are involved, postoperative adjuvant chemotherapy, usually with 5-fluorouracil and leucovorin, has reduced recurrence by 40 to 50%. Age per se should not be considered a contraindication for surgery. Okay. Patients that have localized rectal cancer, the standard care involves a multidisciplinary approach. If the patient had stage 4 metastatic colorectal cancer, the standard of care includes systemic chemotherapy with or without antibody therapy and surgical intervention. Next cancer is gastric esophageal cancer. It's about 60% of esophageal gastric cancer arises in patients 65 years old and older. If the patient is fit and he has resectable disease, we can consider one of two: perioperative chemotherapy with radiation or perioperative chemotherapy in conjunction with surgery. A multidisciplinary approach, including oncology, radiation oncology, and surgery, is very important from the beginning of the decision-making process. If the patient is old and he has recurrent metastatic disease, he will get too much benefit from palliative chemotherapy, not just only to improve survival, also improve quality of life. Next cancer is prostate cancer. The prevalence of prostate cancer in men 75 years and old is over 1 million. It's a very huge, really, prevalence, with more than 60% of all new cases diagnosed in men more than 65 years old. Actually, there's increasing, most of men with prostate cancer die with the cancer, not from it. With increasing life expectancy, older men may experience symptoms from progressing prostate cancer. Actually, the patient with prostate cancer, the most common approach for them is watchful waiting, especially if the cancer is localized. Okay, with life expectancy less than 10 years, and if the patient also has significant comorbidity, we just do watchful waiting, and or if the tumor is small and well to moderately differentiated. Okay. The advanced prostate cancer cannot be cured, and this advanced prostate cancer affects patients whose disease had spread beyond the prostate or are symptomatic. Can affect also patients with biochemical recurrence only, like rising in the prostate specific antigen with no evidence of the disease. As it mentioned earlier, the initial management for the patient with advanced prostate cancer is hormonal therapy or androgen deprivation therapy. The problem of this therapy, it has several side effects such as hot flushes, sexual dysfunction, osteoporosis, metabolic syndrome, falls, and physical performance problems. Next cancer is bladder cancer. Age is independent risk factor for this cancer, especially transitional cell cancer of the bladder. The median age of the diagnosis of the bladder cancer is 65 years in men and 75 years old in women, with peak incidence at 85 years. With advanced age, there is increased risk of detecting higher stage and higher grade cancer. When you want to treat patient with cancer, we have to consider therapy for older patient with cancer. Overall benefit should be weighed against adverse effect and remaining life expectancy. Okay, now we will move to the renal cell cancer. The average age at presentation of the renal cell cancer is 64 years old in both sexes. More than 60% of cases diagnosed incidentally with the renal cell carcinoma, compared with 1970s when only 10% of cancers were found by chance. Thus, more patients are diagnosed with early disease. Okay. The treatment for the local disease could be radical or partial, should be surgery, radical or partial nephrectomy, or you can also treat it as a palliative therapy, like radiofrequency or cryotherapy. The growth rate of small renal cell cancer is low, and the metastatic disease occur in 1% of patients. In asymptomatic patients or patients who are frail with limited life expectancy, active surveillance can be proposed. Now we're going to move to hematologic malignancy. We'll start with acute myeloid leukemia, or AML. AML, it's the problem of the AML likely to be refractory to treatment and also has a smoldering course for which only supportive care is administered. The poor prognostic factor for AML is increasing age, okay, and also independent of cytogenetics. Patients with myelodysplasia who have no excess blast or overt leukemia but are neutropenic and have recurrent infection may benefit from intermittent GCSF therapy. There is actually the value of immediate chemotherapy for older patients has been established, but choice of treatment remain controversial. Other form of malignancy, hematologic malignancy, is CLL, or chronic lymphocytic leukemia. It's the most common leukemia in the Western region, and the median age for this leukemia is 61 years old, and the diagnosis most often will be incidentally. Treatment, it's mainly only required just to control a life-threatening or symptomatic complication. It's generally healed. Unless we can only provide treatment for that patient have life-threatening complication or symptomatic complication like notably infection or marrow failure. There is complication from CLL that in 25% of the patient can develop autoimmune anemia or thrombocytopenia. So investigate the mechanism of any decline in peripheral blood cell counts. Then we will move to lymphomas. We'll start with non-Hodgkin lymphoma. Non-Hodgkin lymphoma is actually worsened with age. The prognosis worsened with age. So the old patients are more susceptible to complication of intensive treatment. There is two most common form of non-Hodgkin lymphomas are diffuse large B-cell lymphoma and follicular lymphomas. They discovered that when you use CHOP, or this actually combination chemotherapy, which indicates cyclophosphamide, hydroxy downdraubicine, oncovarine, and prednisone. When you use this CHOP in patients with diffuse large B-cell lymphoma, they discovered that there's significant improvement of this lymphoma when you add rituximab with this combination therapy. Treatment of follicular lymphoma is more controversial. Also, the localized tumor is curable with radiation. Regarding the Hodgkin lymphoma, it's bimodal. That means can occur, there is actually two, the curve is bimodal, so it can early in life or late in life, with a second peak late in life. Compared with younger patient, older patient with advanced disease respond less well to therapy and have shorter survival. Most older patients tolerate modified version of ABVD like chemotherapy. ABVD is actually a combination also chemotherapy. It's adriamycin, finplastin, bleomycin, and then finplastin sulfate, and the D for dacarabicin. Okay, so most of the patient can tolerate this ABVD like chemotherapy without life-threatening bone marrow toxicity. The last hematologic cancer is multiple myeloma and monoclonal gammopathy of uncertain significance. These two cancers have classic triad. This triad is moroplasmacytosis, which is plasma cell considered to be in the bone marrow, more than 10% of the cell in the bone marrow. Secondly, lytic bone lesion. And thirdly, is monoclonal gamma therapy in serum, urine, or both. In the MGUS, it's very common in older people, okay, and it must be distinguished from myeloma. Low risk MGUS can progress to multiple myeloma or lymphoma by 1% per year. The treatment for multiple myeloma and monoclonal gammopathy of uncertain significance required symptomatic or progressive lytic bone lesion or recurrent infection or serum paraprotein increase. When the serum paraprotein increase or there is any lytic bone lesion or recurrent infection or the patient is symptomatic, you can give him treatment, otherwise no need. And now I come to the end of the cancers, okay? And I can just give a brief summary about the important point. The incidence and prevalence of cancer increase with age. On older adults, more often present with advanced stage disease. Screening older population for colon and breast cancer can lead to early detection of more curable lesions. Older patient can have less physiologic reserve than younger patient, but unless a specific comorbid illness is influencing baseline organ function, cancer treatment with curative or palliative potential should be offered to most patients in most settings, regardless of age. In general, surgery, radiation, chemotherapy, and hormonal and biologic therapy are safe and effective for fit older patients. Cancer treatment, especially chemotherapy, should be individualized with appropriate precautions taken relative to the patient's comorbidity, vital organ function, and underlying health status. This is best done with a comprehensive geriatric assessment and interprofessional approach. We need also to know that do not recommend screening for breast cancer, colorectal cancer, or prostate cancer with PSA test without considering life expectancy and the risk of testing, overdiagnosis, and overtreatment. Also, assessing remaining life expectancy should involve a comprehensive evaluation of health status and include disability, comorbidity, and geriatric syndrome. By this slide, I end my presentation, and thank you for listening.
Thank you, Dr. Lena.
Yeah.
Thank you for your time and presentation. Can you unshare your screening?
Yeah, sure. Thank you.
Dr. Nadir, should I move forward with this case summary, or should we go for the next presentation?
I think you can go to the next presentation. Thank you.
Yep, thank you so much. So as we are running out of time, I would like to have Dr. Bijay Shrestha and Dr. Niki Shrestha to go for their second presentation on tackling virtual interviews, tips and tricks. Thank you. Dr. Lena, please unshare your screen.
Yeah, okay. What happened? I do.
Dr. Bijay, are you there?
Yeah, I'm just trying to share my screen. Can you hear me?
Yes, we can. Thank you.
Can you see my screen?
Yes.
Okay, thank you. Good afternoon, everyone. I'm Bijay Shrestha, and I'm with Dr. Niki to just present on the topic tackling virtual interviews, tips and tricks. Since our first presentation was quite long, so I will try my best to keep this presentation short and hopefully informative. Since pandemic, one and only platform for us, lots of people, and especially to get into the residency program, virtual interview has plays a has played only one platform. So since virtual interviews can be, it can, there are different opinion towards it. It has lots of advantages, and at the same time it can be challenging. So today we'll be just discussing few tips and tricks which can make the interviews smoother and we can be more confident about it. We have we can see here the setup uh, about the virtual interviews, and it all depends upon an individual, how he or she wants to present in interview. So we'll be discussing about it in details in coming slides and just focus on the tips and tricks of the virtual interviews. So beginning with this, first of all, we have to prepare in advance. And we always need to research on the program ahead of time and check out their websites and look for what the program is really looking for. And it is always recommended that we have to practice the interview questions with our friends, with our uh, colleagues or experts' opinion we can take. And it is advisable to just review our ERAS application and personal statement in detail and meticulously as well. And the next thing is testing the technology. It is very important that we need to check the internet connectivity and confirm that if our camera and microphone are working. For example, investing on a good web camera with well-built in microphone is a good idea. And we can choose, there are different options, like we can go for Logitech, a webcam. It just takes like 60 to 70 bucks. And if you go for that, it can be very helpful as well. And we'll have the good quality as well. And the next thing is we need to determine where we're going to take the interview. For example, our room with optimal lighting, preferably near a window or a blank wall to guarantee we are the focal point of the conversation. Whether we sit on our living room couch or in our home office, the main thing is to keep the surrounding tidy and clean. Basically, the thing is to be uh, we have to be presentable, and also we have to just focus on eliminating the distractions. We can, for example, we can turn off the television, silence the cell phones, and close any nearby windows to muffle the neighborhood traffic noises. Another important thing can be we have to think about the good background. There are some options. The Basically, the idea is to avoid the distractions at the end, and a different individual can have different choices. For example, some can go for a plain background, some can keep paintings or portraits, or even we can go for digital background of the software we are using. And the thing is, we have to keep the area of the room clean and quiet. Moving towards another important point, it's like showing up on time. We always have to think like these virtual interviews is also the interviews like as if we are arriving for an in-office. So it is advisable to be prepared at least 15 minutes early of the interview and enter the video promptly promptly at set time start time. So beforehand we have to go, prepare of the software where we are going to give the interviews, and we need to use correct software. So that kind can be Zoom, Webex, Skype, and we have to just be prepared for that. And also, if you can do, we have to consider a test call with a trusted friend to work out any kinks in the connection so that our main interview can run smoothly. And another thing is we need to dress for success, even though it is remotely. So we have to dress for the success. That means groom yourself as thoughtfully as you would for an in-person meeting. So we have to look polished and professional. For example, men should consider wearing a button-up shirt, blazer, and a tie, while women should consider a dress or skirt and blouse. It all depends upon the individual, but at the end of the day, you should look polished and professional. And professional dress up will make a great impression. And personally, you will feel confident. Studies shows that people feel most authoritative, trustworthy, and competent when wearing formal business attire. So this is also very important. And another thing is body language. We have to sit up straight, smile, and keep the camera at eye level. We need to focus on the camera when talking and not on the image of the interviewer. So we can practice this before the main interview, and we can also record. For example, we can record the Zoom meetings, and we can see how we are talking. So it will be very helpful at the end of the day. So, and also the main thing is communicate with the confidence. We can just generate our confidence or show these things by maintaining eye contact, even if through a laptop, and it helps foster a sense of genuine connection and attentiveness with the interviewer. And another thing is stay focused and visibly engaged. It can be done by practice, active listening, and stay engaged in the conversation. Just be a good listener and just try to listen to the interviewer what he or she is trying to say. And also consider nodding the head to give affirmation of understanding while they talk, and asking clarifying questions when necessary. So it is always better to ask if you are confused, if you are not uh, getting the points from the interviewer. And one last thing is, don't rely on a cheat sheet, but be prepared. We have to be prepared with common interview questions that can be asked, and we can get these common interview questions in different platforms from our seniors, from our colleagues, and yeah, and we have to prepare for that. Also, we have to be ready with the questions that we would like to ask the interviewer. Interviewer always want us to ask some questions, so we have to be always prepared for that. And if possible, we have to memorize. We have to avoid the memorizing each response, because it might sound like robotic or overly rare things, and it is not interviewer. It is said that interviewer don't like these things. So at the last, and we need to be ourselves. At the end, I would like to say it's just 15 to 20 minutes interview that can change your life. So we have to be prepared, but at the same time, we don't, we can't show that we are overdoing the things. So be yourself like that. And to summarize, some tips and tricks is like prepare in advance, show up on time, dress for success, even it is remotely, think about the background, and make eye contacts with the camera, stay focused and visibly engaged, and don't rely on a cheat sheets, but be prepared. Yeah, thank you so much. Yeah.
Any questions? Thank you so much, Dr. Shrestha. I
Thank you.
think we can move on the next presentation.
Yeah, thank you.
Sure. Thank you. Next presentation will be on project management, the basics and tools. That will be presented by Dr. Sushma, Srinivas, Dr. Naureen, Syed, and myself. I'd like to have Dr. Naureen to start with that. And let me share the screen. My bad, the wrong one. Can you see my screen?
Yes, I can, Dr. Mihir.
Okay, let me play. Go ahead, Dr. Naureen.
Thank you so much. And good afternoon, everyone. Thank you, Dr. Nadir, for giving the opportunity to present today. So today I'm presenting on project management, me and my colleagues, and I will be presenting the basics. Dr. Sushma will be presenting the tools, and Dr. Mihirkumar will be presenting the overall. So what is project management? So before talking about what is project management, let's talk about what is a project. A project is a series of tasks that needs to be completed to reach a desired outcome with collaboration and careful planning to keep the project on track and on budget. It has a definite goal. It interrelates with different activities and tasks. It's finite in duration. It provides a unique product and service. It consumes resources. It operates under scope, quality, cost, and time constraints. And it utilizes team and based on personal integrity and trust. Next slide, please. So what is project management? Project management is the application of knowledge, skills, tools, and techniques to meet the project requirement and achieve the desired outcome. It is defined as the process of steering a project from the start through its life cycle. The main objectives of project management is to complete a project within the established goals of time, budget, and quality. The life cycle starts when the project is initiated and ends when the project is either completed or terminated in any way. At the end of each phase, there is a decision point where stakeholders decide whether or not to complete the project or terminate it. Next slide, please. So what is the history? How project management came into existence? The history of project management is old, from the invention of the wheel to the construction of the Giza pyramids to the development of the device we are reading on. So the practice became more refined in the last 100 years with methodologies being developed, starting with Frederick Taylor's The Principles of Scientific Management in 1911. Then Henry Gantt introduced the eponymous Gantt chart in 1917. And T-Check Ohnos implemented the rudimentary form of Kanban and Lean in their manufacturing units in the 1950s. In 1969, the Project Management Institute was formed. And over the years, the nature of the market changed. New methodologies like Agile were introduced that refined the project management processes further. Next slide, please. So why project management? Project management is a way to get organizational energy and efforts to flow horizontally towards the customer and across the departmental barriers. It is recognized as a core competence. It is a discipline in this area. And there are certain criteria that needs to be complete in order to be a successful project. And the criteria are completion on time, completion within the budget, and completion within full functionality. Next slide, please. The values and advantages of project management. So the project management, apart from stimulating productivity, improving transparency, and providing a clear vision to the team, it can bring the following advantages: effective communication, effective resource management, improved customer satisfaction and relation, flexibility and high risk tolerance, improved team morale, higher quality of the output, improved productivity, and retrospective learning. Next slide, please. So the Project Management Institute has identified 9 areas of knowledge within project management, which we use to manage our projects from start to finish. And these areas include integration, scope, time, cost, quality, human resources, communication, risk, procurement, and stakeholders. Next slide, please. So the life cycle of project management. The life cycle defines the beginning and an end of a project, representing all the phases together. When defining the project's life cycle, the first phase is noted as step 0. The step 0 is usually the visualizing and the conceptualizing of the project. And according to the Project Management Institute, most life cycles have 4 or 5 phases, but they can have more. Next slide. So the project management phases starts from initiation and it ends on closing. These are the 5 stage phases, and in order to discuss one by one, so the step 1 is the initiation, and this is often considered the most important stage. The project initiation phase includes all the preliminary work that must be done before any other project activities can take place. It has 4 categories: building a project case, conducting feasibility report involving the stakeholders, and creating a project initiation document or project charter. The output includes required stakeholders' approval to proceed to the next phase. Next slide. The planning is the second stage of the life cycle, and it includes the details of the project and creates a successful project plan. These details can be divided into 4 categories: scope, resources, time, and communication. And the output is a detailed plan, a project communication plan, a budget baseline, a project scheduling, individual project goals, scope document, and updated stakeholder registry. Next slide. Execution is the biggest stage of the project life cycle. It usually starts with a kickoff meeting. The project team members are coordinated and guided through the proper project communication for project execution according to the approved project management plan. The decisions and actions are implemented. It is important to keep a log of issues and to make updates of budget and other planning documents. The output is working towards the solution development. Next slide, please. Step 4 is the monitoring and control of the project life cycle. So the cost, the time, and the performance of the project are compared at every stages. It is necessary adjustments that are made to the project activities, resources, and plans to keep things on the right track. So the monitoring and the control output is includes the project progress reports. So next slide, please. This is the final step of the life cycle of project management, and it includes the process of finalizing the report, reviewing and delivering the project to the customer, submitting the final reports. Project should only be considered closed when all stakeholders are satisfied with the successful completion of the project's objective. After the closure, the team members and other resources are released for work on other projects. So the output includes an approved project result and learning that can be applied to similar projects in the future. Next slide. Yes. Popular project management approaches. So the project management approaches offers a collection of processes, methods, tools to manage and accomplish project activities. They ensure consistency, simplify complexities, and lower the cost and reduces the risks. And there are a number of well-established project management approaches which are available. And these include phased approach in project management, lean project management, iterative and incremental project management, critical chain project management, product-based planning, process-based management, and project production management. So the main reasons for failure of a project. Any viable project is prone to fail due to one of the following 5 reasons. It can be resource deficiency, insufficient resources to complete the project, It can be inadequate time frame, having trouble completing the project on time, unclear goals, lack of detailed documentation that lead to inappropriate results, poor managed stakeholder expectations, project scopes, changes that are not agreed upon by the stakeholders, inadequate risk management, failing to establish the risk associated with each product. Next slide. So in the project management, team building and communication is an important part. The team depends upon the size. The size and the role of the team depends upon the project needs. The team members may fulfill one role or more. Team member communication processes are the effective communications among relevant teams and stakeholders. It includes project collaboration tools to share documents and feedback and to keep the tracks on the state phase. Key factors in project management communication includes objectives, messages, audience, and channels. And the three important steps in project management communication process includes the planning communication, manage communication, and monitor communication. And an effective communication process is critical to the project success. Next slide. Team building and transparency is the creating a project management system in which all team members can access all relevant information about a project easily and efficiently. It provides trust among the team. It keeps the work on track. It improves the team productivity. And how to improve project transparency. Let everyone see the big picture. Let everyone see the data. Make collaboration easy. Share calendars. Regular team meetings. Choosing the right management tool. Next slide. The collaboration is the key to project success. And it includes the following steps. Improve communication within the team. Be as transparent as possible. Get everyone involved. Encourage members who take the initiative. Remove any physical barriers. Optimizing office meetings. Use project collaboration tools. And keep the team happy and motivated. Next slide. So the methodology and framework in the project management. So the project management methodology offers a clear project roadmap that lists all the steps required to deliver a project successfully. However, the framework provides only structure and direction to a project. It is unlike the project management methodology because it is neither too rigid or too detailed. So this chart describes the differences among both. In the framework, it gives an overview on how guidelines can be implemented, while in methodology, it offers only rigid rules and practices for completing a project. The framework offers space for creative adaptation while methodologies are rigid. Framers is preferred by experts. Methodology is preferred by beginners. The framework is hard to develop and implement performance metrics. However, the methodologies, we can include all preference guidelines in a granular details. The framework leaves room to include other tools and practices. Methodology cannot be embedded with other practices and tools. And the famous examples are traditional project management, PMBOK is a framework example, while Prince2 is a well-known project management methodology. Next slide. So the 10 key project management skills and competencies to master in 2022 are the following: leadership skills, effective communication, planning and strategic thinking, team management, time management, task management, risk mitigations, expert negotiation skills, critical thinking, and all while using the right tools. From here, Dr. Sushma will start, and thank you so much for listening. Thank you.
Thank you, Dr. Naureen. Can you all hear me?
Yes.
Yeah.
Thank you, Dr. Nadir, for this opportunity. So today I'll be talking a little bit about the tools that we use for project management for researchers. So it's important to have tools like Dr. Naureen mentioned. There are a lot of steps in project management. So it's important because it'll help reduce wasted effort. It'll help track progress and respond quickly to deviations from important aims while keeping creativity intact. These factors can also help researchers work smarter with available resources and better compete for funding by demonstrating a positive track record. The project manager executes the project in accordance with the project specification. The progress is being reported to the project steering group by using progress reports. And each report provides a review of research content and resource situation. Next slide. So the process of managing an academic research project is very challenging, and it's important to have tools to streamline everything. And it's hard, especially for those who are new to research. So they are tracking. You have to track multiple deadlines and tasks. You have to communicate with team members, tracking the comments from professors, peer researchers, vendors, managing complex paperwork and data, and keeping on top of changes and revisions. Next slide, please. So good tools have to be cost effective because like you all know, we are all students, and if the tools are very expensive, we may not be able to afford it. It has to be easy to use because some of them, the user interface is very hard to master, and they have to have good features. So it's always better that we have one app or one software that will cover everything, so it's easier to collaborate. And otherwise we'll have to have multiple different softwares and put everything together. That can be very confusing, and again data can get lost. And it has to be compatible in the sense it has to work for our project, because some of the softwares that are available may not offer what we really need. Next slide. So different kinds of tools for researchers. So we all start with first we all read and we come up with a topic. So for that we have to find good journals for our topics, like PubMed is one, Google Scholar is one, Embase, PsycInfo. So we need to first find good journals, and then we have to do data collection. Data collection, depending upon the type of study, we have to have good data collection tools where we can note the data, help manage, and protect all while protecting the privacy of the patients. And next important thing is to have plagiarism checkers, because when we start writing, we have to make sure we look for no plagiarism before we submit it to the editors. And another thing is the project management softwares by itself. So some of the data collection ways are, I'm just going to skim through all these things. So some ways are interviews that we can conduct with patients. Then other things are libraries and surveys and questionnaires, case studies, focus groups, observation, and photography and videography. Then plagiarism checkers, like Trinka is one, Turnitin is one, DupliChecker, QText, Copyscape, Grammarly is one of the free plagiarism checkers, and CopyLeaks. So now coming to the project management software for research. So these are some of the ones that we found that are recommended for the year 2022. So one is Asana, Trello, Jira. This is good only for 10. This is free only for 10 users. Then Wonderlust, ClickUp, Codebox, WorkZone, Paymo, Workday, Evernote, Wrike, ProofHub, Zoho. And these are some of the free softwares that are available. Grant Pro has only a free 14-day trial. Then Pro Workflow, Airtable, Team Gantt, KissFlow Project, and Basecamp. Next slide. So here I'll talk about some of the pros and cons of some of the commonly used project management softwares. So one is Open Project. This offers an intuitive suite of tools at a minimal cost. Basecamp facilitates collaboration between research teams members with features such as to-do lists, messaging, file sharing, assignment of tasks, milestones, due dates, and time tracking. Its cons is it's $20 per month, or it's only free for teachers. Trello, this can help manage research projects by keeping everyone on time and on task. It uses a distinctive interface based on cards and lists, and maybe especially useful for smaller projects. Cons are it's not always the best tools for complex projects. Next slide, please. A Basecamp, it has tools to create dashboard, Gantt charts, budgets, and status reports. Activities can be assigned to team members and progress monitored. It also has a tool for agile project management. While the software is free, this may be installed and maintained on a local server, and there will probably be costs associated with this. So Proof Hub, this is ready to use. It has ready to use project templates, task management, time tracking, and project reporting, team collaboration like chat, notes, and discussions, file management, and online proofing. This is the 14-day free trial with all features. So like I told you, it's a paid one. So ClickTop, one of the best project management software for research. Great choice for both individual researchers and research teams. It is cost-effective, cross-platform, and easy to use. It organizes your research tasks into lists and then drags and drops them to create a workflow and best suited for your needs. It also adds, there's an option to add comments and attachments to your task to keep track of all the relevant information related to your project. Cons, it does not allow users to create folders. Some users have complained that the user interface is not very user-friendly. So Rike, this is a cloud-based project management tool that helps team manage projects from start to finish. It offers a variety of features such as task management, file sharing, time tracking, and reporting. Plus, it's easy to use and can be accessed from anywhere. This makes it a great choice for researchers who need a tool that's both versatile and easy to use. ClickUp, sorry, there's a mix-up there. So that Zoho, it's a very cost-effective tool. It's one of the cheapest project management software available on the market. It's also a cross-platform tool that uses interface of Zoho projects and it's a straightforward to use. But it has poor customer support, which can be a con. And Evernote is a cross-platform note-taking application that helps you organize your life. With Evernote, you can take notes, capture ideas, and track tasks. The best part about Evernote is that it is available on various devices, including desktop and mobile devices. Evernote groups your notes into notebooks, which are similar to file folders. It's meant to be used as a note-taking tool, so you can use it to jot down ideas or things you notice with a text camera or voice note. Some of the cons are some of the features are not available on free accounts. It is slow to load on older devices. It can set tasks and deadlines, but no weekly report on who did what. It can be challenging to collaborate with others on a research project. Bit.ai, it allows researchers and teams to collaborate, share, track and manage all the knowledge and research in one place. An easy to use minimal editor that supports Markdown. It helps a collaborative real-time editing and communication with peers. It adds any type of digital content, like you want to add images, videos, etc. to your Bit account. And a content library to save all your media files for quick access. Smart Search allows anyone to search and find any files, images, documents, links, etc. Next. So Asana, it can be tailored to meet the demands of a wide range of academic research projects. Asana was created so that any size team can track their progress and address their research related issues in one location, eliminating the need for endless meetings, email updates, and notes. Cons, it can be challenging for teams with more complex workflows. It can be difficult to track tasks when there are larger number of collaborators. It is best suited for teams who will be working closely together. So this was a little bit about the project management softwares. Like, earlier we all didn't have the option of softwares. So people would, collect all the data manually. They would also, save, through records. That all that had a lot of disadvantage and issues. So there was a chance of losing the data. There was a chance of, privacy issues and biases. So all this has been, managed because of the software. And like we mentioned earlier, good project management software will help manage and collaborate everything. So the project is more streamlined and everything goes smoothly. Now my colleague Dr. Mihir will be demonstrating two of the project management softwares. Thank you so much for listening.
Thank you so much, Dr. Sushma. Thank you everyone for listening us. Basically, as Dr. Sushma said about the online software, so as Dr. Naureen explained about the basics of project management, and also Dr. Sushma explained about the tools and some of the platforms. I'm going to briefly explain or show a little bit about Basecamp. Since we are running out of time, I will probably not go through the Evernote right away, but if we have some time left afterwards, after our fourth presentation, then we can probably jump on Evernote. But for now, I'm just gonna show a little bit. So everything has been talked about. Project management is simply just managing projects. When you're especially doing research, when you're working here, there are a lot of things you're going through. Many of our research fellows here, they are involved in more than one project. So sometimes it gets very hard to focus on, each and every project and go through that. So I am actually going to share a screen right now on one of the platform I chose. Let me stop this one and let me start. Yeah. And no, I'm not going to be able to. Sorry about that. Let me try this again.
While Mihir is
Yes.
while you're trying to get the screen share, I'm just gonna thank everyone who presented previously. Thank you so much. This is great. And for the project management, I think every one of us.
Okay, let me see if I can do now. No, not this one. Okay. Okay, can you all see now? So this is the Basecamp. I've been using Basecamp for more than 4 years now, so I can really relay myself with using this. It's a very nice platform for managing your projects. If you have more than like 4 or 5 projects, let me jump on that. If you have more than 4 or 5 projects, you can separate them out. You can name those projects, and like different projects you can manage. Each and every simple project has like their own message board, to-do list. In the message board, you can post your announcement, your pitching your ideas, progress updates. You can communicate with your team members. To-do list, you can make a list of work that needs to be done. You can assign items, you can set the due dates and discuss further on the given topics. You can also schedule your important dates, subscribe, or you can subscribe your events in Google Calendar or iCal or Outlook. you can also store documentations over here, and not only just that, you can share your documentation file, images, and spreadsheet. And also you can do group chat. Group chat in Basecamp is commonly known as campfire, where you can simply chat with your group informally and ask questions, share any important news or anything like that. And also has automatic check-ins where you can create recurring questions, so you don't have to pester your teammates about what's going on. Then also you can set up your work-life balance goals into that. So I am going to share. Let's see. All right. So this is one of my groups I've been using. We have like 4 different projects going on with the schedule and assignments. Also, you can select here. I'm just randomly going to select one. As you can see, there are a lot of people assigned here. You can see all the members, message board here, to-do list, documentation, campfire. You can start the chatting here, scheduling, and any like a project activity. You can simply look here. You can also see who has done whatever kind of work over there on the side. And you can also access with the dates and whatever was done in the past. You can also attach the documents over here, any flyers or anything. So that helps with your project. And also look into the activities, whatever the activities done before. So it is pretty easy to use software. I'm just gonna end sharing here. So basically it helps you when you're working on your particular research. It helps you to manage your project in simple way. So any questions? Thank you so much, everyone, for listening us, and we can move on to our next presentation. I will ask Dr. Avinash, Bakhtiarpuri, and Dr. Marium to talk about their next presentation, which is on linear regression in Google Sheets.
Thank you so much, Dr. Mir. Let me share my screen.
Sure.
Do you guys see my screen?
Yes, it's loading.
Okay, it's loading. Let me know when it's come.
It is there now.
Okay. Thank you so much, Dr. Nadir, for providing me an opportunity. Today, my topic is the linear regression. Me and Dr. Marium will present. So before going to present the linear regression on the Google Sheet, let's have an idea what is a linear regression. So in this topic, we will introduce like what is the regression. We can use simple regression and when we can use it. And we will learn the basic quantities which are involved in the simple linear regression. And we will learn how to use the regression in the real applications. So regression is used to study the relationship between two variables. We can use the simple regression if both the dependent variable and the independent variable are in the numerical. If the dependent variable is numerical and the independent variable is categorical, it is best to use the analysis of variance. And I will show you in the next slide what is a dependent variable and what is the independent. So first, before go to the graphical representation of the regression, let's have an example. The following are the situations where we can use the regression. For example, testing if IQ affects the income, in which the IQ will be the independent variable and income will be the dependent variable. Or we can say testing if the number of cigarettes smoked affects the blood pressure, and the number of cigarettes smoked is the independent variable and the blood pressure is the dependent variable. Okay, so this is main important slide displaying the data when both the dependent variable and the independent variable are the numerical. So in this graph, you can see like this data 60, 90, 120, it is given in the numeric forms. And here the income 4,000, 60,000, 80,000, it was given in the numerical form. And we can represent the data in the form of scatter plot. These dots, black dots you are seeing, these are the scatter plots. So in this graph, we have a y-axis, and here is the x-axis. Okay, and the independent variable will always be on the x-axis, and I will note it as IV, independent variable. And here is the y-axis, we have a dependent variable, dv. Okay, and we try to form a relationship between these two variables, and we'll draw a line. In this case, is a straight line. And I will explain what all this means, and what we try to understand is as the independent variable is moving or changing. So what happens to the dependent variable? Does it goes up or does it goes down? It will totally depend on the independent variable. So if the independent variable increases from 60 to 90 to 120, okay, the dependent variable increases as well, 40,000, 60,000, and 80,000. And this relationship, we call it positive relationship. So let me draw a graph. So for example, at the 60, the income will be 40,000. And at the 90, the income is 60,000. And at the 120, the income is like here. So as the IQ increases, the income increases. This relationship is called the positive linear relationship. And on the other hand, if the independent variable like this x-axis increases in that manner and the dependent variable decreases in that manner, that representation is called the negative linear relationship. So this is all about the graphical representation. So now for the linear regression, we have an equation. And before I'm going to discuss the equation, I will again draw one graph. Again, this is X, this is Y. I'm going to put X here, IQ, which is independent variable. Here is the income, which is dependent variable. Okay. So my independent variable and dependent variable will become the income. So as IQ increases in that direction, the income should goes up in that direction. And this is a positive relationship. And we develop this equation. In this case is a Y is equal to B naught. B naught from where this start, this line start, B naught. And the point where it intersect, it is called B1. So B1 will become positive if it is positive linear regression, and B1 become negative if it is negative linear relationship. And it will become 0 if there is no relationship with B and X. So now if we change the, for example, this is the positive relationship. Okay. Now if I change the x-axis, here is the time spent on the Facebook. And here is a negative relationship with the grades. This is the grades on y-axis, dependent variable. So it will become a negative relationship. The more time spent on a Facebook, the lesser will be the grades. The lesser time spent on a Facebook, the more will be the grades. So this is the negative linear relationship. And let me clear all the drawings. So this is the equation for the positive relationship. This is for negative. Y is the dependent variable. As in the graph, it shows income. X is the independent variable. It is the IQ. B is not B1, and E is the error. The most important thing is that in the graph representation is that the X, which is the independent variable, and the Y is the dependent variable. The X is what we can change, we can manipulate, or we can control. Okay, while the IQ is the IQ, and the Y, which is the income, we can't change it. That is dependent variable. So IQ is an independent variable is what we can control and manipulate. The income is dependent on how much the IQ of the person have. So this is the whole idea about the linear regression. So if the B1 is positive, X has a positive effect on Y. So X increases, Y will increases. If B1 is negative, X has a negative effect on Y. So as X increases, Y decreases. And if the B is equal to 0, there is no effect of X on Y. The errors are normally distributed, while these are some on the graph, these are the outliers. If you can check by performing the scatter plot, these are the outliers which are circle red in the graph, and we can simply be removed from the analysis. And in the last is a hypothesis testing, and a regression test the null hypothesis. H0, it means there is no effect of X on Y, means there is no effect of IQ on the income. It means B1 is equal to 0. Versus an alternative hypothesis, there is an effect of X on Y. It means B1 is not 0. There must be some value. So if the null hypothesis is rejected, we reject the hypothesis that there is no relationship. And hence we conclude that there is a significant relationship between X and Y. And how do we know if rejecting the null hypothesis? We'll perform a regression in SPSE software, and we will look at the p-value of the coefficient B1. If the p-value is less than 0.05, we reject the null hypothesis. The variable is significant, means otherwise we do not reject the null hypothesis. It means the variable is not significant. Thank you so much. And the rest of the presentation will be presented by Dr. Marium.
Thank you, Dr. Avinash. I don't know if they can hear me. Hello?
Yes, we can hear you.
Okay, thank you. Thank you, Dr. Avinash, and thank you, Dr. Nader, for giving us this platform to learn and to share knowledge. Today, I will be just explaining explaining linear regression using the Google Sheet. I will share my screen first. Share, okay. I believe that everyone can see my screen, hopefully.
Yes.
Okay, thank you. Okay, so the first thing that everyone will do is, of course, to have a Google account, to open their internet browser and to log in their Gmail account. And here we will go to Google Sheet, first thing, and then add new sheet. Once you open your spreadsheet, then you will change the name, for example. That's the first thing. For example, we'll do it linear regression. And then you will enter your data that you had from your cross-section research or from your research or any data that you had. I already pre-made one so we can save time. And today I will be given an example about simple to variable linear regression. And as Dr. Avinash talked about, he said that simple regression, simple linear regression is when we measure the influence of one variable on another variable. There is another type called the multiple linear regression, which I will not give an example of. The multiple linear regression is when more than one variable have an influence on another variable. So here I will be, as I said, give an example of the simple. For example, this is the example that I decided to go with. We have conducted a cross-section study of 16 patients age 96, for example, 96 month to 150 month. And we want to determine if the height, which is the y-axis, that will be in the y-axis, varies with the age. The age here will be the independent variable. It's the variable that you can control or manipulate, while the height will be the dependent variable and it's the outcome. So we want to determine if the height vary with age. And the height, as I said, is the outcome. So what will you do first? That you will enter your data here. As you can see, these are the age that I will go in months, and these are the height in centimeters. So the first thing that you will do, of course, is you will click on your data, and then you will drag all of them, highlights all of them, and then you will go to inserts, and then charts. Okay, and as you can see, the first thing that happened that they showed me the chart here. And here's the chart editor that I will explain everything about it. But first, if this didn't pump out in your computer, the first thing that you will do, if you didn't pump out, for example, you didn't have it, so you'll just click on your chart, and this 3 dot, you will press on it and edit charts. So as we can see here that we already have the charts in scattered type, in a scattered way. So chart, yeah, here, the first thing, if it wasn't scattered as this one, you will go to the chart in setup, you will go to a chart type, and press, of course it will be, you have a lot of types. So mine was already in the scattered one. If you didn't find it, you will go and, yeah, here's the scattered one. Another thing that I notice here that it's very condensed. So just change here the height and make that the minimum value. I will make it 90. Yeah, 90. And the maximum to be 160. Okay, as you can see that it changed. And here I will also change this. I will make the minimum to be, this is the X. Okay, I think that I was supposed, this is the height, sorry. The height, I will make it, I was looking to this, I'm supposed to look to the height. The height, change the minimum to 120. Sorry. 120, and the maximum to, for example, 140. And as you can see, it is spread now. Now we'll change the age, the minimum 90 and the maximum 160. And as you can see here, that you have this scattered linear regression. Now I want to change the trend line. So what will happen that from here, from customize, I will go to series, and then I will go to trend line and choose what type of what type do I want. So here we want the linear regression type, and we will also show the equation, and of course show the R square. And we all know that, we know that the R square is the amount of variation in the X that is explained by the variable Y, which is the height. So now that we have all of this, we have the equation, we entered our data, we have the age, we have the heights, and we have our equation. The next thing that is very important to know is the R, which is the coefficient correlation. So another way that we can find the R is, this is very simple. We already know that R equals the square root of the R square. So we can do this, equals S Q R T of R, which they already gave it to us, 0. Which is here, 0.84. And then we will close it and enter. And this is the number of R. And as you can see, that R is close to 1. And from the chart, from R, R tells us the relationship, the correlations between the X and the Y. And it also tells us the direction, the direction of the correlation. So The R squares will always be positive because you're squaring if you square any number, it will give you a positive number, but you won't know if R is negative or positive unless you look of course, to the chart. And as you can see, that the way to know if it's positive or negative, as Dr. Avinash said, that if you go to the left and if it's rising, as in this one, it's going up, then that's a positive correlation. And because ours is going up, this is a positive correlation, and it's also close to 1. So this is a strong correlation coefficient. Another thing that we use when we do linear regression, that we calculate or we predict, one of the outcomes to predict the Y. So we can use it to predict a new value of Y for an X value that is not actually observed. For example, if we said that, for example, here in 160, the age of 160 months, we don't have a value for that, and it didn't show here in the charts. So another way that we can predict a height for an age of 160 is do simple calculation that they already gave us. They already gave us the equation here. So here, if for example, we said that we want X to be 160, and we want to predict the Y will equals, I will just put this equation down. So 0.166 multiplied in X, which we said that 160, and then plus 108 and enter. So now we were able to predict Y with only knowing the X. And this is the main reason that they use the linear regression slope, because it helps you to predict Y. And as you can see that I was easily able to predict Y just using the simple equation that this Google Sheet provided to me. And yeah, that's it. That's pretty everything about the linear regression and the importance of it and how it can help you measure the R value, the R square, and the R value, and also to predict and height. To predict the outcome from an independent variable. And that's it. Thank you.
Thank you, Dr. Marium. Thank you, Dr. Avinash, for nice presentation. With that, we concluded our today's fourth presentation. I want to, Dr. Marium, you can unshare your screen.
Okay.
And I'm very thankful for Dr. Nadir to give us this opportunity for Brown team to present this presentation so far. And Dr. Nadir, if you want to take over from here.
Thank you so much, all of you. Thank you, Dr. Mihir. And thank you, everyone, the presenters and all those who attended. And just I want to confirm with you all for the presentation. Everyone did great, excellent work. Thank you so much. So if you have questions, please jump in if you have any comments. The next part, I think we want to just, if you have a little bit of minutes, if anyone wants to update as far as project, how you are doing, and if you have any questions regarding your projects. So this is great stuff, great explanation, demonstration, tutorial, and awesome. Thank you, everyone. So if there is no question, I'm going to share the screen for next week. So this is just the items or agenda. For next week, we can talk about oncology, from maybe how to write grant, and then IRB. So we will focus on that, and maybe we can start because it's gonna be soon starting the preparation for the yes, alaikum salam for the interview. Go ahead.
Yes, hi. Just asking about you have a webinar subject like it's COVID vaccine efficacy. We're sharing with Dr. Akila, but I'm not sure what's going on with that and when we're going to present it and how to do that.
So Dr. Akila, I think, is going to take her secretary in the coming days. After that, or during these coming days, you can discuss with the team as far as the organizing who will be presenting what part, and then identify what specific date you want to do the webinar, and then we can work on how we advertise that. So we need to create a panel or a flyer, and then you can share to either Facebook or WhatsApp group or whatever you decide, and then you can take it from there. So in the next few days, you will have some information from here.
Okay,
But
thank you
in
so
the
much.
meantime, you can work together as far as who will do
Yes,
what.
I think now we went with like we finished with everybody finished its part, and just we need to show you that thing, and then we will go with which one you will advise to do.
Excellent.
Thank you so much.
Thank you. Go ahead, Shaima.
Hello, Dr. Nader. How are you?
Very good, thank
you. I want to ask about we are like I'm preparing my ERAS, and I was a little bit confused where to put the fellowship. Is it under the research experience or in the education? If you can give me insights about this.
So in the past, people I think did a different way, but there is no wrong answer. So you can put it in both places. So you are getting the education, and you are also getting the skills and the experience. So it's going to be at the part where it's research related. And if you are involved in multiple projects, then you can list all these projects. If you submit it, you can mention that. If you have some accepted abstract or papers, then you can list that as well in the research part. In the educational part, so you can add that as it's part of your education.
Okay, and in the education part, there's a question asking if we're gonna get a degree. It's not a degree, right?
It's not a degree, sorry. Yeah, it's not.
Yeah, and like, is there a strict, like a clear end date?
There's no end date. It's usually 1 year. If you get matched, then you will say goodbye. If not, some people stay, some people go to do some other, like some of the first batch, they went to do a fellowship in Mayo Clinic, for instance. So yeah, you can do other stuff. Or you can.
Thank you very much.
Later. Thank you. Yeah.
Mm-hmm.
Good question. Any other question? So thank you so much, Mahir, for organizing and leading the team and presenting the Zoom meeting. Thank you, everyone. We will see you next week. If there is no question, if there is any, shoot me an email or text me. I'll be happy to chat with you guys. Thank you. Have a wonderful day or night. See you next week. Assalamu alaikum.
Thank you, Dr. Nader.
Thank you so much.
Thank you, Dr. Nader.
Thank you, Doctor.
Thank you.
Thank you, Dr. Nader.
Thank you. Have a great
Dr. Nader.
Thank you, Dr. Nader.
Thank you. Bye-bye.
Thank you.
Thanks.
Assalamu alaikum.
Have a great day.
Alaikum salam. You too, thanks.
Thank you, Dr. Nader. We'll see you next week, inshallah.
Thank you, Doctor.
See you, inshallah. Assalamu alaikum.
Thank you, Doctor.
Thank you. Have a good day. Take care. Go ahead.